Cardiology patients experience enormous numbers of transitions as they move through our healthcare system. There are the obvious ones, which are the physical transitions that take place as they move from location to location within a hospital. There are the transitions that occur as they move from the hospital environment to the rehabilitation and outpatient environment. But there are also the emotional transitions that take place as they encounter different caregivers, different nursing staff, different physician providers perhaps. And then there is the difficult transition which occurs in thinking, because remember that most of these individuals have experienced some sort of life-altering event. In many instances, they have come to hospital in extremis, perhaps even having myocardial infarction or an episode of heart failure in which they couldn't breathe. So the transitions that take place require education about the disease process, what has occurred and what to expect. In addition, there is the education as to why are we moving from here where I feel comfortable and know the staff to a place where I'm not so comfortable. And the interplay of those fears and transitions results in anxiety and, in many instances, situations in which the patients and their families seek comfort. Unfortunately, if we do not well educate them, that comfort comes in the form of coming back to hospital. If you can imagine for a moment that you've just suffered a myocardial infarction, had a stent placed, perhaps faced death, and now have a large number of medications that you're trying to keep track of. You have new sensations and awareness of things happening with you. That is a situation that none of us want to face. It's our job to help them transition through those changes. The education, for instance, regarding their medications is critical. We know that the simple act of teaching them what the medications are for, what the medications mean, and what the dosing strategies imply helps them with that transition. Simple things like telling them what to expect after they've had a heart attack, explaining to them that it's normal to be afraid and that it's okay to call. It's good to come in and see the provider in the clinic. All help to mitigate those transitions. The transitions are also critical because it is in those early days that we as providers have the best chance of providing the educational resources that help them not only transition from hospital to home, but then from the recovery period into the maintenance of health, which reduces our long-term health care costs.
So one of the challenges for, I think, cardiology and transition of care is, number one, we're just not aware of some of the complexities. After the patient leaves the hospital, there is no incentive. It gets handed off, and our physicians go about taking care of the next patient. And that's probably an overstatement. A lot of groups have got heart failure clinics and things of that nature where we're attempting to manage those patients after discharge. But I think the focus probably needs to be increased significantly. But that's where some of those tools come into play, for instance, such that we can really monitor patients' adherence to the protocols that have been established for them, taking their medications and staying on the right diet, getting a little exercise, et cetera. But there are lots of other challenges out there, and one of them is obviously the IT piece of that and the transfer of electronic health information. One system does not talk to another system very effectively, and I think that's another challenge that has to be overcome.
So the challenge very specifically with hospital readmissions is that in most cases, patients fall into a black box and they are obviously not in the hospital where the hospital knows how to take care of people, and not quickly in an outpatient department where people know how to take care of them. They're very, very specifically in between. So I believe when we think about all of the good things that cardiologists and hospitals have done to make the quality of care better, this is one that in the past has fallen between the cracks. Hospitals are very good at figuring out what needs to happen to a patient in the hospital. Hospitals have started to get better at figuring out what has to happen to the patient after they leave the hospital. On the other end, doctors are very good at figuring out what to do with the patient when they see them. But it's this black hole in between of readmissions that's the major issue here. And there are hundreds of other quality measures. This is but one. But the idea is the transition of care is to work out specifically how to deal with those patients. So for example, hospitals have gotten very good at discharge planning. There are people, usually nurses, who work with the patient and the doctors to figure out what to do when the patient goes home. But those people are in the hospital. There are certainly clinics that deal very well with a patient when either they or the discharge planner calls up and says, okay, you need to be at the doctor's office in a week. So those scheduling issues now happen. But we also know that patients do not necessarily keep those appointments, and that the discharge planners, for all that they do very good things, the day the patient goes home, they may not follow what they were told to do. So the issue here, the issue for patients and the issue for the healthcare system, is how to fix that time in between.